We're just waiting for people to join. So we're about 13 minutes away. So just hanging tight, and we should be starting in a few minutes. Thank you for coming, guys.
Sounds good. Thank you.
Thank you. about the 5-minute warning, so we'll start in about 5 minutes. Okay, we'll start in about 3 minutes. Hope everyone's doing well. Grab a beverage of your choice, and we'll get started in a little bit. All right, y'all, we got two more minutes, so we'll kind of keep the invite list open, and then see some familiar faces joining us today. So welcome. Again, this is very relaxed, so enjoy yourself, sit back, and we'll learn some stuff during this quarantine period of our lives. You know? All right. Okay, y'all. So it's 7:30, and I just want to welcome you guys. We're going to talk a little bit about athletic hip disorders. And so for anyone who doesn't know me, who's joining us here today on this webinar, my name is Edwin Cadet, Dr. Edwin Cadet. I am a orthopedic surgeon who specializes in sports medicine and shoulder surgery at Raleigh Orthopaedic Clinic. I am fortunate to be one of the team physicians for NC State University Athletics, as well as a head team physician for Raleigh University. And the athletic hip injuries are a particular interest of mine. Prior to coming to Raleigh Orthopaedic Clinic, I was a sports medicine attending at New York Presbyterian in New York, and that's where I served as the Director of Hip Arthroscopy. So it is a clinical interest of mine, and I'm glad that you all are able to make it. So we're going to talk a little bit about athletic hip disorders, things that I see in my practice, and things that you may see as healthcare professionals or even patients who have experienced some of these hip disorders. So we'll move forward. So I just want to give a shout out to the NC State women's basketball team for their success and their historic journey through the ACC tournament as ACC tournament champs. It was just honored to be part of the team, and the athletic trainers and coaches, players did an amazing job. On the bottom right is Cassie Daly, who's the team physician, athletic trainer for the basketball team, and does a wonderful job with the girls. So I just wanted them to give them a proper congratulatory note, seeing that the season was unfortunately cut short. So I'm a educational consultant for Smith & Nephew, as well as fellowship. We do receive fellowship funding through Smith & Nephew, but there are really no conflicts regarding this talk. So a couple of ground rules for the talk here. We're going to I'm going to mute everyone for now, but if you can actually write questions on the chat section, and I'll address them at the end. And we're going to try to keep this talk to about 30 minutes, so at the end we can talk, and I'll even unmute people, and people can ask questions. But if you have any pressing questions, just write them on the chat section, and at the end we'll get to them. So as we all know, or may not know, groin injuries do represent a lot of injuries that we see as sports medicine physicians. Approximately 2 to 5% of all sports injuries do involve the groin. And because of the complex anatomy of the hip joint, the diagnosis is sometimes unclear in up to as many as 30% of cases. So you can see that that can be a high number of patients that we don't really have an immediate diagnosis for. And again, the reason for that is the hip anatomy is very complex, and there may also be not just one injury. There may be a confluence of injuries that may cause the patient's symptoms. As healthcare providers, we always have to rule out other non-musculoskeletal causes of groin pain. So this includes appendicitis, particularly if you're dealing with young athletes. This is a really important thing that you have to rule out. Aneurysms, hernias, either inguinal or sports hernias, which we'll talk a little bit more specifically at the end of this talk about how to differentiate between the two. And this is a very common injury that I see a lot with rotationally demanding sports like football, soccer. Other abnormalities involve the GU system, like urinary tract infections, prostatitis, scrotal or testicular injuries in the males. Gynecological injuries and gynecological conditions in female can very mimic hip pain in certain conditions, and even kidney stones. And there's a very important connection between the hip and the spine. It's actually called the hip-spine connection. And you can see a lot of referred pain into the groin and into the hip area through lumbosacral disease, such as lumbar disc herniations or slip discs or slip vertebrae. So this is really important to be able to differentiate where these sources of pain may be causing groin pain or hip pain. So certain disorders that I see in my practice, and I'm gonna really just focus on a couple. If we have time, we may be able to get to a couple more. This thing called hip impingement or femoral acetabular impingement. And we'll talk a little bit about the pathomechanics of this disorder and how this can actually cause labral tears, which is the next thing on the topic. As I mentioned, we'll talk a little bit about sports hernias and how you can differentiate a sports hernia with an inguinal hernia. Adductor strains, again, very common in sports that are rotationally demanding or sprinting sports. Avulsion fractures, stress fractures, and if we have time, we can go into a little bit of this thing called greater trochanteric pain syndrome, or otherwise commonly known as hip bursitis and gluteus medius and minimus tears. So we all know the hip anatomy. We may not know the hip anatomy, but the hip anatomy is very complex. You know, essentially the bony anatomy is a ball and socket joint. So if you can see my cursor, on the left side is the femur, all right? This is the ball part. And the femur has a couple components to it. It's got a neck part, which plays an important role in this thing called labral tears and femoral acetabular impingement we will talk about. And then the socket's also very important. So the socket has this covering around the joint, which is called the labrum. We're going to talk a lot about the labrum and the importance of the labrum in hip stability and providing the nutrient environment for the joint. You can see this kind of shiny covering on the ball, which is the articular cartilage. Now, the articular cartilage is different than the labrum, just because the articular cartilage essentially is like the ice of an ice rink, and it allows our joints to move very fluidly and very easily. And so you can see how certain conditions like FAI can cause injury to the articular cartilage surface. So we'll talk a little bit about that. So in terms of femoral acetabular impingement, this is a relatively new concept that we have been talking about. Professor Gans out of Switzerland described this in 2003, where he found certain types of patients' anatomies or people's anatomies can predispose them in developing these very painful labral tears or early osteoarthritis. And he talks about three mechanisms of femoral acetabular impingement: one of cam impingement, pincer impingement, or a combination of both. And the next slide shows this very nice schematic of that. On the top left is what the normal hip should look like. This is a cross section, so I'm going to orient you all to the slide a little bit, or to the picture. Again, this is the femur on the left, and this is the cup on the right. This is the acetabulum, and this is the femur. All right. Notice on the femur, it's very spherical, and there's a nice transition between the femoral head and the neck. There's a concavity to it. This little triangle, and we'll see this on MRIs in future slides, is the labrum, okay? And then, so Gans talks a little bit about certain mechanisms, right? So this thing called pincer impingement, where you have an overhang or excessive coverage of the femur along the head-neck junction, all right? So it overhangs across the neck, so if the hip is brought into flexion, it will prematurely contact this area and cause a crushing injury to the labrum. Conversely, the deformity for cam is on the other side. So rather than having the overhang on the cup side, you're having it on the ball side. And you can see you lose this concavity at the femoral head neck junction. We have this bump, all right? And we'll show this intraoperatively, okay? And then, so in this scenario, you get premature contact of not only the labrum, but also the underlying cartilage, which can cause a lot of significant injury to the articular cartilage. And more frequently, we see a combination of both scenarios, where you see both overhang and also a bump, both pincer and cam impingement. So this is just a finite element analysis model that I did several years ago, showing an area where there's a large cam lesion, and you can actually get premature contact. And also you can see as the head contacts this area, it actually kind of levers the head outside the joint. So you can see how the soft tissue structures in this area is seeing high load, premature load that can cause injury and cartilage damage with repetitive stress. So what is the labrum? The labrum, again, we talked about that in that structure, that little triangle structure. Is a really important structure. It's actually a part, it's collagen, the cartilage. But the most important part of the labrum is its function. It increases the articular surface area. What does that mean? So it increases the area by which the hip joint can move fluidly and without resistance. It also maintains this thing called the fluid seal. What is that? The fluid seal is like a suction cup where it preserves fluid within the central compartment. The central compartment is actually where the head articulates with the cup. By maintaining this fluid seal, you can actually distribute compressive forces uniformly throughout the joint so that not one particular area in the joint is seeing excessive load. So that can prevent early osteoarthritis, as Gans hypothesized. And furthermore, because you're keeping all this fluid in within the central compartment, it helps you maintain a very nutrient-rich environment for the articular cartilage and its health. So it's really important structure. So we didn't really know whether or not by actually repairing the labrum, we could actually preserve this fluid seal effect. And so I took this to the lab several years ago, and this was actually one of the first studies to look like that if you actually can fix the labrum, you can actually preserve the fluid seal. Conversely, we also do things such as labral reconstruction, which is this picture on the right where you actually can take a graft when you actually have to resect the labrum because it's such poor quality. And in attempts to try to preserve that fluid seal function, you can actually do a graft and reconstruct the labrum, not very much like we do for ACL reconstructions, where we're reconstructing the ligament. And we actually proved that you can actually see a nice restoration of fluid seal, not back to normal levels, but relatively good restoration of fluid seal with repair. So I like to have this slide, the Mona Lisa, right? So I used to say this to the residents, I say this to the fellows. The eye sees what it knows, all right? And also the beauty is in the eye of the beholder, right? So when I see this picture, I interpret this picture differently than many others who are watching this, or those who have seen this painting throughout the world. So the reason I brought that slide up before is because patients always come in and say, listen, I have a labral tear. This is a soft tissue injury. I don't need x-rays. X-rays tell me a lot. So if someone may look at this x-ray and say, well, it looks pretty normal and nothing's crazy going on here. When I take a look at it, I'm starting to see different things. I'm starting to measure certain parameters that may indicate a patient may have FAI, or you can actually notice subtle stress fractures, or you can notice ascites pubis, which is a degenerative condition along the pubis symphysis around here. So x-rays are very important. Sometimes I've even identified tumors or revulsion fractures. And so these are really important preliminary studies that we need to get. Again, eyes and the beauty is in the eye of the beholder. So when I look at this, I'm looking at findings consistent with impingement. You can see that there's a little bit of diminished femoral head offset here. And the alpha angle is elevated. Normal is usually 42. In this patient, 70 degrees. I see a little bit of overhang on the cup side. That's a consistent sort of impingement. So x-rays are really important. We always talk about MRI, and so this is kind of a representative image of an MRI. This is an MRI arthrogram, meaning that we've injected some fluid inside of the hip to improve sensitivity and also specificity of the exam to detect labral tears. Again, you may notice that this little triangle structure that we had in the previous slide, and this is the labrum. The fluid will go through the path of least resistance. So you can see the fluid makes this nice little right turn adjacent to the labral attachment, and that's your labral tear. So when do we get MRIs? So, x-rays are always important first. We talked about that. We can sometimes we don't need an x-ray. Sometimes you see a patient with a significant degenerative joint disease, and so your diagnosis is already made. We also get MRIs when I have some concerns for stress fractures, and quite often these stress fractures are negative, do not appear on x-rays. And this is particularly during running season. So for me, when I was in New York, it would be between September and November that corresponded to the New York Marathon. Here in Raleigh, it's more like April and through June. And so you always, when you have particularly a female runner that is training for a marathon and increases the intensity of their training precipitously over a short period of time, and has groin pain and gets worse even with weight bearing, that's something, and you get x-rays, they're normal. For me, that's an MRI until proven otherwise, or a stress fracture until proven otherwise. And when patients fail to progress with non-operative management. So treatment options. So this is really important. Every patient that we see who has FAI, I would say the vast majority, very few. Non-operative management is the mainstay of preliminary treatment. And what is that? So we rest the athlete or the patient, kind of have them back off on the aggravating activity. So activity modification comes along with that. Physical therapy is quite useful in these patients to help restore motion and as well as strength, periarticular strength. Sometimes ultrasound guided injections, whether or not via diagnostic approaches, so using lidocaine to see whether or not their pain is actually coming from inside the joint or outside the joint. And also ultrasound guided injections that I can provide in the office is also important. You can also use it, cortisone injections to help lower inflammation. The role of PRP is controversial, but I have found that to be useful in patients who actually do have some areas of cartilage delamination, and there's really limited side effects with a PRP injection. Surgery, if everything fails, patients have failed conservative management 3 to 6 months, then surgery is a very good, reliable, and very useful option for these patients. And our goals as surgeons is to restore normal anatomy and address soft tissue injuries such as the labrum and cartilage lesions. In the past, the mainstay was open, and when you do an open FAI surgery, many times that involves a surgical dislocation of the hip. So the benefits of that is that you can see a lot. You can see the entirety of the head. You can address femoral cartilage lesions. You can really visualize the vessels, which I would argue arthroscopically you can see these vessels. But there's a morbidity to that, so you're in the hospital for several days, larger incisions, chances of heterotopic bone ossification, which means that extra pieces of bone may form around the joint because of the trauma of dislocating the hip, and just a longer recovery for patients. So that certainly can help. Now, I would say the mainstay of FAI surgery, at least in my hands, is arthroscopic surgery. So when do we refer to hip arthroscopists? Usually patients who have failed 3 to 6 months of physical therapy and activity modification, NSAIDs. Sometimes that number is not absolute. So sometimes patients are in so much discomfort despite injections, anti-inflammatories, they're unable to perform physical therapy because the pain is so bad. And sometimes in those scenarios, we often have to intervene slightly sooner than waiting the whole 6 months. Absence of osteoarthritis on x-rays is, I can't tell you how many referrals I get when a patient has bone-on-bone arthritis and they say, well, I have a labral tear and I need surgery. Hip arthroscopy cannot reverse the arthritic changes. So if a patient has significant arthritis on radiographs, those patients do not do well with a hip scope. And we'll talk a little bit about that in the future. When the radiographs, diagnostic, therapeutic injections, MRI, and clinical exam supports their findings of FAI or abductor tears or whatnot, this is a good time when a hip arthroscopist services can be needed. And like I said, not everyone who has a labral tear needs a hip scope. And quite honestly, a lot of patients with hip labral tears have had them for a while and can be successfully managed without surgery. And again, hip arthroscopy is not effective in the patient with osteoarthritis. So when we do a hip arthroscopy, again, the beauty of this is we do this with minimally invasive techniques. Small incisions, strategically placed to avoid injuries to the adjacent neurovascular structures. And I'm going to take you through a little bit of the steps in a little short video of actually what we do. I think maybe a lot of you haven't seen that. Patients ask me, what do you actually do during this surgery? And I explain this to you. In order for us to actually get our instruments inside the joint, we actually have to apply traction to the joint. So very carefully, we distract the hip between the femoral head and the acetabulum so we can allow our instruments to traverse very safely inside the joint. I want to show you what normal looks like, all right? So this is actually a normal hip. This is the femur on the left. This is the acetabulum or the cup. The labrum is this structure right here. And you can see how it's nicely confluent with the acetabulum, all right? The capsule's in the front. And you see there's no disruption of the labrum and the cartilage surface, all right? The capsule is pink, not red, not thickened. And this is what normal looks like I'm going to take you through a video that shows you what abnormal looks like and actually what we would do to fix it. So this is a view of the hip. You can see the hip capsule. This blade is cutting through the hip capsule. It's thick and red and inflamed. This is the capsule in the front. We're taking some special instruments just to open the capsule. At this point, we got to try to find out our bony anatomy and our bony landmarks. So these are special instruments that can expose this pincer lesion. You see these two mounds of bones adjacent to our shavers. And these are the pincer lesions that overhang and cause this pain. This labrum, I'm going to just pause this for a second. The labrum is to the left, the acetabulum is to the right, and the femur is to the left here. And you can see this large labral tear and divialis cartilage, all right? Now it's just like sculpting. We're sculpting, removing the extra pieces of bone. And at this point, we have to reattach the labrum back to the acetabulum. We use these special devices called suture anchors that have these special types of threads, or called sutures. And we suture the labrum using special suture techniques back to the acetabulum rim. We either can loop the suture around or pass it through the tissue. And you can see how the labrum is nicely reapproximated with the resection of that pincer lesion that we showed. Our work is not done yet. We talked about this cam lesion, right? So usually it happens in both sides. So here's the cam lesion. And again, I'm going to show you this. This is viewing down the femur. So this is the neck of the femur. And that big bump, that area of red I showed you on the previous Gons schematic, that is the pincer lesion. And again, at this point, the case turns into a sculpting case. We're using dynamic intraoperative finding, fluoroscopy, and visualization to better evaluate how nicely we can create that sphericity at the femoral head-neck junction. And again, this is just a sculpting case, and this is probably the longest part of the case in terms of, and this is actually the most important part of the case. Patients who fail hip arthroscopy, generally the unrecognized cam lesions are actually the #1 cause for failed hip arthroscopy. This is a really important study. Femi Ayeni out of McMaster University, he was one of my co-fellows, performed this really nice study and showed predictors of who does well with hip arthroscopy for FAI. The systematic review looking at all of the papers are out there and shows really high-level studies. He found that those patients who were younger, had males who were male, lower BMI, no osteoarthritis on radiographs, and had pain release from a preoperative diagnostic or therapeutic hip injection tend to do the best following hip arthroscopy. Those who did worse were older patients, and older, they referred to older as over 45, female, elevated BMI, osteoarthritic changes, decreased joint space, which also denotes increasing degenerative joint disease. And those patients who had labral debridement over repair tended to do worse following hip arthroscopy for FAI. These are not absolute, I would say, confounding factors, but this also helps me in the office when I'm trying to explain to a patient whether or not they would benefit or not so benefit from hip arthroscopy. So these are certain, this is a very important slide and a very important study. So we're going to talk a little bit about sports hernias. This is something that we see a lot during football season. We see this a lot. So what actually is it? Well, sports hernia is actually a weakening of the posterior inguinal wall. So the inguinal wall is where the spermatic cord contacts kind of flow through there. And this is actually a weakening in the wall. It's not an actually true hernia where you actually get herniation or bulging of abdominal contents through a hole. It's just a weakening of it. It's really hard to actually to see on standard pelvic MRIs. You have to actually get a specific protocol for that. But patients will complain of pain along the inguinal ligament, which is actually the area of the groin. Now, that's outside the hip joint. What I'm going to put through in my cursor, here's the hip joint. Patients will talk about pain here. Sports hernias will talk more on the lower abdomen, kind of where the pubic bone meets the lower abdomen. Maneuvers that may increase the intra-abdominal pressure, that one I have found to be quite sensitive to this is actually pain with a sit-up where you're actually directly palpating that area along the inguinal canal, all right? And oftentimes this can be managed conservatively with rehabilitation, but sometimes surgical management is useful. Now, this is quite different than a conventional inguinal hernia where patients may say, I feel a bulge in my scrotal area or my inguinal area. And women can get this as much as men. There's a more predominance for men to get this with women, but women can get this. Now, what actually is it? So whereas a sports hernia was a weakening of the posterior or the back wall of the inguinal canal, true inguinal hernias are actually a hole in that, or a weakening in that inguinal ring where abdominal contents can actually protrude down. And that's when patients will say, well, I felt this bulge in my groin area. And that's actually some concerning for an inguinal hernia, okay? So that's the difference between those. This is something very common I see as well. If you treat a lot of adolescent athletes, I see a lot of the athletic trainers from state here. And you can see this a lot, even in our freshmen and sophomore athletes. These avulsion fractures. Now, these avulsion fractures represent these fractures where tendon units attach to growth centers along the pelvis. So one of the most common is the ASIS, or the anterior superior iliac spine, with their sartorius muscle, a powerful hip flexor, as well as a knee flexion muscle inserts. The AIIS is where the rectus femoris, so it serves as a partial hip flexor as well. You see that a lot in soccers. And ischial tuberosity fractures, see a lot of them in sprinting and hurling. And this fracture actually holds sort of importance to me, because when I was a junior in college, when I was hurling, I actually sustained an ischial tuberosity fracture. So these fractures, if they're displaced more so than 2 centimeters, you can actually consider fixing them. The vast majority of these avulsion fractures we can treat non-operatively, and a lot of these athletes can heal uneventfully. In terms of return back to sport, it's very variable. It can range as less as 6 to 8 weeks, even up to 6 to 9 months. So, and I think it depends on the level of displacement, and also just whether or not these athletes actually do shut down for a significant amount of time. At least for me, when I injured my ischial tuberosity, I literally had to shut down for 3 to 4 months before I actually could even start jogging. So, and mine was significantly displaced. So again, X-ray is really important. You can see this large piece of bone, which is the ischium, and the ischial tuberosity, and the hamstring tissue right here. You can see that a pretty large fragment that involves from the ischium here. Okay, so this is why X-rays are really important. Stress fractures, really important. We usually see these on the femoral side, but in the track and field athlete, you can see them a lot on the pelvic side. So usually the superior, inferior pubic rami. Femoral side, really something that you have to take very seriously. These sometimes can require surgical management, particularly if they happen on the tension side. And I'll show you a picture of a stress fracture. So a lot of times these x-rays are normal. You have to have a high index of suspicion for these. This is an MRI where you actually see a lot of edema along the medial femoral calcar. See this white area where you can get the stress fracture here. And this is on the compression side. So if you protect the athlete or the patient with protected weight bearing with crutches for 4 to 6 weeks until they're pain-free, they can usually be treated without surgery. When these fractures occur on the tension side, as demonstrated with my cursor, these usually require surgical management because these don't heal and they can also displace. If you see the dreaded line on x-rays along this the side, also that could be an indication for surgery as well. These abductor strains, we see this a lot in sports. So the abductors are the muscles that help us to bring our leg inward. I see this a lot in sprinting athletes, athletes who change direction frequently. So football players, skilled players such as wide receivers, linebackers, running backs that change the direction. Soccer players, you see them a lot. This group of muscles right in the area where I'm demonstrated are in the adductor here are where you can actually see these strains. A lot of times it's diagnosed with physical examination. You always got an x-ray again to exclude a avulsion fracture. Usually pain with resisted adduction, so bringing having the leg bringing toward the midline can reproduce the pain. Sometimes you will get an MRI to just kind of grade the injury, and also can help us with prognosis in terms of how long the athlete will be out for. And also whether or not they could benefit from certain modalities like PRP or other things like of that nature to help to accelerate recovery. And again, usually non-operative management is warranted. There are times where you can actually get an avulsion on the MRI of a soft tissue adductor, and there are some select cases where actually those can get fixed. But again, the number of 2 centimeters, and again, depending on the activity level of the athlete, will help us determine whether or not you could benefit from surgery for that. Unfortunately, usually it's not. So that actually takes us to 30 minutes. I have a couple of other things here, but I want to actually, I'm going to unmute, and I'm going to see if there's any questions here. And if everyone wants to ask some questions, or I will take some questions. And let me just check to see if we have any chats here. So no one's written anything here, but are there any questions out there?
I had a question.
Yeah. Hey,
So, hey, you talked a lot at the beginning about different things that could be confused as hip pain, like several different things. So, at what point do you suggest like we start looking wider, like post imaging or?
No, that's a great question. So again, 80 to 90% of a patient's diagnosis is through the history and physical. So you have to ask them specific things like, hey, do you have any pain with urination, right? So flank pain, right? So that will kind of key you in on a kidney stone, right? Or blood in the urine, UTI, things like that. Does this pain fluctuate with your periods, right? So that may lean more towards a gynecological source. Positional pain. And the physical exam, is really important. I think that that helps a lot to kind of differentiate whether or not, you're dealing with an appendicitis, right? So a patient with FAI is not going to have pain in the right lower quadrant, but a patient with a sports hernia may, right? Fevers, chills, these things can help to differentiate whether or not you're dealing with a visceral source of hip pain or musculoskeletal pain. So for me, even prior to the imaging, but by the time I finished the evaluation, about 80 to 90%, I have a good clue of what's going on with that patient and whether or not this is coming from the hip, whether or not this is coming from their back, whether or not they need to get a urine sample to rule out a a UTI or kidney stone, whether or not they need a referral to a back doctor. So usually, before we even get to the imaging studies, the history and the physical was really critical. That's a great question.
Thank you.
Thanks. It's a great question. I have a question. When patients state, I hear a loud pop, what do you suspect? That's a great question. There's a lot of differentials with that. The most common, and I actually have a slide on that, is snapping hip. So what is that? And so I'll go to that right here. So snapping hip, what is that? You can get loud pops and clicks inside your hip from your hip flexor, the iliopsoas, all right? The iliopsoas is this big muscle that runs from your back into the front of the hip, all right? You can see how this big tendon here wraps right in front of the hip. So you actually can get snapping through a very tight hip flexor, okay? You can also get it through a labral tear, all right? But usually you can get that through a really tight hip flexor. I often differentiate what's internal hip snapping versus external hip snapping. So patients will also say, well, I can hear my hip snap across the room. That usually is your hip flexor, all right? You can also get mechanical symptoms, like I said, like from a labral tear. If a patient tells you that my hip is dislocating, look, watch doc, look, I can show you how my hip dislocates, right? That's not their hip dislocating. That usually is their iliotibial band snapping adjacent to the greater trochanter. That's called external hip snapping syndrome. But the loud audible pop, at least in my experience, usually is your iliopsoas that's tight, could be a labral tear, could be loose body inside the hip, PVNS, but in my experience, it's usually the hip flexor. That's a great question. We get that all the time.
Great, great presentation and whatnot. Very good overview and whatnot. Especially, since I don't really see a ton of hip injuries on the day-to-day. I guess just a kind of a question. What would you say? You talk about these FAIs and just these different lesions. What would you say kind of causes those to maybe occur? And whatnot? Just kind of give me your thoughts there.
So what the question is, what causes the FAI, or what causes the injuries associated with FAI?
Well, just more of the lesions, or that I guess, like you said, sort of cause it.
Yes, this is a great question. So we think that a lot of it is developmental, right? So usually the cam lesion, and actually with wrestlers, we see this a lot. I mean, a lot of these patients will have FAI, but they'll be asymptomatic of it. We think that one reason that patients develop cam lesions is a developmental condition, and due to the sport that they're involved in, it creates certain loads across the proximal femoral epiphysis, which is the growth center, one of the growth centers in the femur. And because of the certain loads that they see with their sport or activity, that can cause this cam lesion. So that's how we sometimes will see particularly cam lesions develop. On the acetabular side, again, it's developmental. Everyone has a certain different anatomy, but not everyone who has FAI develops symptoms. So it really depends on their sport, their activity level, the degree of their deformity, right? We see a lot of athletes who don't have, a lot of non-athletes who have symptomatic FAI, and they're not loading their joints like a competitive wrestler or a football player does, but they still get labral tears. And again, that's because their hip developed somewhat differently, or unfortunately, that they will develop some of these injuries. So at least for the cam, usually it's overgrowth of the proximal femoral epiphysis. On the acetabular side, it's usually just kind of a developmental thing, and that's how these guys develop FAI. It's a great question. Any other questions? Well, I think I'm going to end it right now. So I'm glad everyone was able to pop on the webinar. If you have any questions, you all can contact me. My website is www.edwincadetmd.com, or you can visit www.raleighortho.com. If there are any patients out there, you can call the office for an appointment. If there's any issues you want to talk with me, 919-863-6808. You can ask for me and request an appointment. These slides I can make available to the people who ask, and I probably will post this webinar on my social media page, so you'll be able to again review it again, so that you can have access to the slides. Okay. So thank you all for coming, and I appreciate you guys coming. All right. Be well. All right. Thanks. All right. Bye, all.
All right. Bye.